Good afternoon. Welcome back to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out the program evaluations and give us any ideas that you might have in regards to future topics or future speakers, and then turn those back in. Today, I have the pleasure of introducing Dr. Rakshak Sarda. Dr. Sarda is board certified in cardiology. He completed his residency in internal medicine at Wayne State and then did his cardiology fellowship at the University of Texas at Galveston. He also has a background in preventive medicine. He did a 3-year preventive and social medicine residency before completing his internal medicine residency. He's currently a member of the Iowa Heart Center and a member of the cardiology staff here at Mary Greeley Medical Center, and he has kindly accepted our invitation to update us on heart failure. Please join me in welcoming Dr. Sarda.
Oh, he didn't give me the clicker. Okay. Good afternoon. Thanks for the opportunity. No financial disclosures. I gave a heart failure talk 3-4 years ago. I still have wife and 3 kids, and my allowance has not changed. I still get $50 a month. Some slides are from Heart Failure Society of America. I'm a little lazy, so I just stole their slides and asked for my colleagues from Advanced Heart Failure team in Des Moines to loan me some slides. So I got 45 minutes to talk about it, so we will go fast. We'll try to touch pretty much everything which is well documented and non-controversial for treatment of heart failure. Multiple definitions of heart failure. Every textbook you pick up, there will be a new definition. So it's generally resulting from myocardial muscle cell dysfunction or loss, like in myocardial infarction and character. Usually there is either LV hypertrophy, left ventricular hypertrophy, or left ventricular dilatation. And the mechanism it works is a neurohormonal and circulatory abnormalities. So when we are treating this disease, you will see that there are a lot of neurohormonal drugs being used. And many a times to common people and our patients, it doesn't make sense because the effects of the medications are lowering the blood pressure, and when they already have a lower blood pressure, and when we prescribe those medications, they read that this is for lower blood pressure, and they do not take those medications. So the other thing is it's a progressive, and we use the word often fatal, but everything is fatal at the end. So it's fatal. Patients can be stabilized. And usually the dysfunction and remodeling may improve, and we'll go through those medications either spontaneously or consequence of therapy. So sometimes when there is myocarditis, usually viral myocarditis, they can recover spontaneously, so don't give up on them. One entity which is quite looked up is heart failure with preserved LV ejection fraction. So when you look at an echo report, the heart ejection fraction is normal, 55% or above. And this is a very common symptoms. We see it in our patients all the time, a lot of ER visits with all the time, a lot of readmissions with this thing. And there's classic signs and symptoms of heart failure, and there are no absolute treatments specifically designed for heart failure with preserved LV are still available. A lot of trials are being done, and most of them are negative. So we come back to the treatment of risk factors. So risk factor modification, usually it's exercise, weight control. Hypertension control is a big one, and it's a complete topic. We need to look into myocardial ischemia, valvular stenosis, arrhythmia correction. So you go to the basic what's wrong with the patient's heart, and you try to correct that. Diabetes control is very important. We had a patient last month, or early this month, with thyroid abnormalities and was in heart failure, and we had to correct the thyroid hyperthyroidism. And the big one is sleep apnea treatment. So as America is growing means growing in BMI, growing in waist size, growing in weight, we are seeing a lot of sleep apnea. And people with sleep apnea have a lot of heart failure, and sleep apnea needs to be treated. So if you're not treating sleep apnea, your patients will keep on coming back. That is hospitalization. And we have a sleep lab here at Merrill Medical Center, and also sleep. And this is a little advertisement. My boss is here, so I had to do that. From Iowa Heart Center Sleep Lab also. So here we go. So you can send me the check. So there are certain goals, and these goals have been there for 20, 25 years. Some of you were even not born. Most of the ladies were not even born when these goals were set in. And usually we want blood pressure on the lower side. Not too much low, but on the lower side. There are ADA guidelines which change every 10 minutes, so you please look on those every ADA guidelines for diabetes control. Hyperlipidemia also, we keep on changing the guidelines, so please look into the guideline reports. But usually we want LDLs below 100, at most below 130, and triglycerides below 150. Inactivity is an important factor in risk factor modification or heart failure patients. So all heart failure patients, whether they are reduced LV ejection fraction or preserved LV ejection fraction, need to exercise. And it should be at least 20 to 30 minutes of aerobic activity. I had a funny about that. I do exercise, and I play on Wii, or I do Candy Crush, or I do this and that, but that doesn't include in activity. Obesity, weight reduction, BMI of 30 or less. Again, this is a very touchy topic, and you have to keep on pressing it. That's our duty and obligation to our patients. And I can tell you, most of your complaints will come when you ask somebody to lose weight or quit smoking. But that's how it is. But we keep on saying that. And keep on stressing that somewhere they understand. Now, alcohol is a very controversial issue. And this is a generalized saying for men, 2 drinks, and women, 1 drink. You all have seen those funny slides where the guy is having a big glass of beer because doctor said 1 drink. And when I came to this country many, many years ago, I was in Detroit, Michigan. And the guy gave me the history of alcohol, 2 beers. And my attending said, it's more than that. I said, 12 ounces is nearly 250 ml. I was still counting in milliliters, and it will be 500 ml. And I said, no, that is a 40 ouncer he is talking about. And that is here, again, very common. People will not agree how much alcohol they are drinking. And usually the rule of thumb is, you know your patient, and double it, triple it, quadruple it. And if it is somebody I know, 5 times. Smoking cessation, again, very important. We have Iowa quit line. Too much of time spent, doctors don't get enough time, nurses don't, we have heard it all. So we have Iowa quit line. Please keep on mentioning that. Again, a little sidebar on smoking, that most of the people, 90% of the people who quit smoking fail in the first attempt. That doesn't mean they cannot get a second, third, fourth, or fifth attempt. So please keep on working on that. Dietary sodium, again, there is a lot of controversy going on. Some people are salt sensitive, some are not. But the general rule is 3,000 milligrams of sodium. And if you cut your total sodium intake in American diet, you will still get that. And the usual thing about diet is when we say if it comes from a plant, eat it, and if it comes from a plant, don't eat it. The plant is where you have preserved food, and most of the preservatives somewhere or the other you will have the slide. The one thing about obesity is, which is very common, and you see a patient and they will say, oh, I was big all my life. they were born 300 pounds. I don't know what they mean to say about that. And the second thing is, oh, it runs in my family. So when they say obesity runs in my family, it means nobody runs in my family. So that's how it is, and I am part of that. Let's talk about evaluation. It's very important we evaluate your patients correctly. And first of all, as a physician and nurses, now remember, we have a lot of ancillary staff here in the audience, and heart failure treatment is all about a team approach. Doctors get only a very little slice of treatment. We just boss around, say something and all that, but the team approach, the nurses, the other ancillary staff is the most important component in heart failure treatment. And I think it has been documented again and again, and we thank you from the medical staff, from the physician staff. I thank you for all the help you guys provide us in taking care of these patients. So we should have a good history, and we should see how much they are limited by physical activity. And in Iowa, we see two different ways. There are patients who have extreme expectations, and they are 85 years old, and they are feeling terrible because they cannot do things they were doing when they were 40 years old. And the other people are, oh, I do fine, but as soon as they walk from here to there, they are short of breath. So we need to find their limitations. Echocardiogram, I see some echo lab people here. Echocardiogram is the foremost test for assessing heart function, valvular abnormalities, myocardial thickness, etc. So a good echocardiogram with a decent report is very, very essential. And we need to look for myocardial ischemia by stress testing, coronary angiogram, and other modalities. We have to look for life-threatening arrhythmias. Heart failure patients, as you know, can die suddenly, and we'll talk about it in a little bit. So we have to evaluate for their life-threatening arrhythmias. Identify what makes them go into heart failure. What are the situations? Is this the food? Is this the activity? Is there anything else going on, arrhythmia and other things? And identify comorbidities and barriers to adherence and compliance. And this is very, very important. And again, a visit, a doctor's visit is 15 to 20 minutes. I used to get 15 minutes, then I pleaded with my boss, and they gave me now 20 minutes a visit. I spent 20 seconds with the patients, 18 minutes with the computer, and 2 minutes, or maybe a minute just relaxing or breathing. But that is the reality. So the nursing staff and other people, they are very important in finding out. And I would ask my MAs and nurses, what do you think? And they will say, this morning I saw a patient, amlodipine was filled in January for 90 days, and guy can swear he was taking amlodipine twice a day. So it's once a day dose, you had 90 pills, and how can you take twice a day pill for 5-6 months now? But those are the compliance issue and other things. And we had a patient upstairs yesterday who had some financial difficulties and would say, oh, I'll take the medications. And when we prodded further, it was five medications, $50. There was no way he was going to fill it. So he is going to come back to the hospital with the readmission. So we need to identify these. Now, weight is a big issue. Now, these are last-minute funnies. I just got it done in 2 minutes or 3 minutes before we started. Pardon me, this was the first which came through Google. So whosoever did it, Mark, whatever his name is, thank you to him. Weight is the biggest problem, and Terry is there, and some other people from 4th floor are there, that how much fuss we make about weight. And somewhere you would see that weight checking and documentation in a decent and correct way is very, very important. 4 years ago, I said the same thing, or 3 years ago, whenever I was here, and we have made some strides, but again, management, please look into it, that weights are documented very well. Now let's talk about, it's 12:24, let's talk about treatment. And our treatment right now, we already talked about preserved LV function, and now it is treatment for LV dysfunction. And the first drug which came up were ACE inhibitors. Again, it did not make any sense. The people had low blood pressure, and you are giving a medication which lowers blood pressure. But then there is HOPE, Europa, and multiple other trials which showed a consistent improvement in death, rehospitalization, and quality of life. So the nurses out here, please remember, when you give us a call that patient's blood pressure is 100 and the patient is on an ACE inhibitor, can I give the medication? I would say yes most of the time. So don't be afraid if the blood pressure is 100 and the guy has non-ischemic cardiomyopathy and is not having symptoms to give ACE inhibitors. ACE inhibitors make patients feel better. They improve the outcome, as you can see. Where does this? Oh. Is this? Yeah. As you can see, these are placebo, this is drug, placebo, this is drug, and that makes the outcome, and there are multiple studies about ACE inhibitors. So be very sure that you do not hold ACE inhibitors in patients with congestive heart failure, LV dysfunction, because they decompensate. ACE inhibitors are also very good, useful drugs. So if you have coronary artery disease, peripheral vascular disease, stroke, diabetes, and if you are post-MI, then ACE inhibitors with beta blockers. It's extremely, extremely important that we understand, and how do ACE inhibitors work is a complicated mechanism, and now we are going through renin, angiotensin, and aldosterone system and trying to hit every possible corner because we have seen that that improves outcomes. Now, the other important thing is the dosing in ACE inhibitor. So you have all these ACE inhibitors, captopril, enalapril, fosinopril, and those are all prils. And you sometimes ask a patient, were you on any pril? And these are the prils. And if you look at the dosing, they are pretty high doses used in clinical trials. So captopril, 50 milligrams TID. If you look at enalapril, 10 milligrams BID, lisinopril, 20 milligrams, and quinapril, 80 milligrams. And renopril 10 milligrams, and our patients are on 2.55 milligram dosing. So we need to increase or try to attempt to increase the dosaging of ACE inhibitors as much as possible to the dosages which were used in clinical trials. Again, if you look into real life data where there are a lot of publications, we are unable to achieve those numbers. Now, a lot of patients are intolerant to ACE inhibitors, and in patients who are intolerant to ACE inhibitors due to cough, then ARBs are recommended. And now we have losartan and valsartan, which are generic, so they should be cheap and we can use them. Now, if patients are not tolerating ARBs, angiotensin receptor blockers, then the combination of hydralazine and oral nitrates. Now, we have some pharmacists here, and Bidal was one combination which was approved, and it's too expensive. So nowadays, we tend to use hydralazine and Imdur or isosorbide dinitrite, which is 3 times a day. Imdur is one time a day. So we have kind of, for compliance issues, gone to hydralazine and Imdur, which becomes cheaper combination. Is that correct? Yeah. Okay. And patients who are intolerant to ACE inhibitors from hyperkalemia or renal insufficiency, whether you give them ARBs or ACE inhibitors, they are going to experience the same effect. So in those patients, we tend to use hydralazine and Imdur combinations. So sometimes the patients will say, I don't have coronary artery disease, or I don't have chest pain. Why am I getting this nitrate? Because that's what they think nitrate is for. Then you have to describe this reason. Again, one is a venodilator, one is an arterial dilator, and somehow this combination works. The study which was done, we'll come to that study later on, the AHAV trial, which was in African Americans, but I think it's a generalized consensus now that some sort of afterload reducer and a venodilator needs to be used if you are unable to use ACE inhibitors and ARBs. Now, Beta blockers are another treatment. They are for symptomatic and asymptomatic patients who have LV ejection fraction less than 40%. And if you are post-MI, we are using beta blockers. If you have angina, we are using beta blockers. And there were multiple studies on beta blockers. And if you see, there is a consistent mortality benefit. How many drugs are there which gives these mortality benefits? I'll bring up some medications later on in the presentation, and you will have 2%, 3% mortality, 5% mortality reduction, and they charge you $500 a month for those medications. And we are using them left and right, but sometimes we see these patients who are not getting these cheap medications. And all of these are generic. All of these should be $4. Now, sometimes the bisoprolol, we get PA for authorization and all those things. I don't know why, but these are generic, age-old. It's when I was young drug, and look at the target doses. Our target doses are quite high, and we are unable to achieve these dosages. So most of the benefits in these studies were when patients were at target doses. So to satisfy Michelle, we can say, okay, patient is on a little beta blocker and a little ACE inhibitor, and she's happy because she does the tick, tick, tick. Okay, we have followed the guidelines and all those things, but as physicians, we should be trying to push the dosages. Just a side note, Michelle usually orders pizza, and nowadays she's not ordering pizza from me, so that's the reason I'm hurting on my allowances. Okay. Now let's go. What happens with the recent decompensation, And when the patient comes here, again, these are all practical views we are talking about, is after we start beta blockers after the volume status has been good. And we have successfully discontinued the IV diuretics, put them on ACE inhibitors. And I usually tend to start beta blockers before ACE inhibitors if there is tachycardia or if there is an arrhythmia or post-MI. Usually, I'd like first an ACE inhibitor and then beta blockers. I think we should be discharging patient on beta blockers, and if we have to keep them a day or two extra, we should keep them in the hospital to see how they will react to the beta blockers. And that's what the consensus and guidelines are. Now, if patients are on a beta blocker, you can keep them on beta blocker unless and until they develop a cardiogenic shock. Their volume overload is that much that you are unable to get fluid off them, or they become severely bradycardic or symptomatic bradycardia. And sometimes we tend to, if they come on Corec 25 BID, we say, okay, let's cut it half or quarter it out and try to keep them on some beta blocker because we want to avoid abrupt discontinuation of beta blockers because there's a reflex tachycardia. And then again, you can reinstate it. And usually we follow a 2-week rule that every 2 weeks we try to put one medication on titrate. But if we know that the patient has tolerated these medications, we can up-titrate it fast. We may have to see the patient a little earlier in the office, but you can up-titrate it fast. Now, patients will come, I have diabetes, and because there is written, if you have diabetes, don't take beta blockers, unless until they have recurrent hypoglycemia. Diabetics can use beta blockers very safely, and I think physicians here in the audience will agree to that. If we have resting limb ischemia, I do not do it because it can worsen it. And if they have ongoing asthma, COPD exacerbation, we are hearing wheezing and all that, then not. And if they have symptomatic hypotension or bradycardia, we talked about it. Active bronchospasm, do not do it. It will get you in trouble. And all of us know about one patient where we got in trouble because of active bronchospasm, and somewhere the beta blocker was given. Do not worry about concomitant disease of COPD. Sometimes toprol work very well in COPD. Unless and until there is an exacerbation, we do okay. Um, Again, these target dosages we talked about, I want to mention it again, that these are high dosages which are our target dosages. So toprol 2550 is not going to do too much. We need to go up because in studies, if you can see, the mean doses was 160. Okay, so this is a new thing which we just got in America. The trial was called SHIFT trial, and this is a new drug which is inhibitor, IF inhibitor. It's F stands for funny. There's a funny receptor channel which we call it, and this is ivabradine. Its market name is Corlenor. It was approved in Europe earlier, but in America this was approved this year, I think, or last year. And the data, the trial was called a SHIFT trial. It was a systolic heart failure treatment. So these people have systolic heart failure. Again, remember, these are not people with preserved LV function. These are people with systolic dysfunction. And there was an 18% reduction in composite endpoint of death and rehospitalization. And if you look into these numbers, how they put these numbers is the absolute risk reduction was 4.2%. So 18% of relative risk reduction and absolute reduction. So 4.2% is as good as it gets nowadays. Usually we approve the drug for 2%, 3%. And if you look into these multiple graphs, which were stolen from Lancet, and if you see, this is optimal medical management. Now, there are in heart failure trials, we do not find any trials where it's a placebo-controlled trial as such, because you have, or I should not, they are placebo-controlled trial, but you have to have them on optical management, medical management. What is that? That is ACE inhibitors, beta blockers, spironolactone. We'll come to that. So this, the reason I put this slide here is ivabradine is a drug which reduces heart rate, and it works on an SA node and an AV node, and it does not work on ventricle at all. It does not have any negative inotropic effect, and it is to be used only in people who are in sinus rhythm and after treatment, like heart rate above 70 or so. And you can start it at 5 milligrams BID, increase it to 7.5 milligrams BID. So it's a newer drug which does not decrease blood pressure. So even if your patient has 90 to 100 millimeters of blood pressure, you can still give it a try. The side effects mainly are atrial fibrillation, and there are some eye side effects which can happen with this because of some receptors, the same receptors in the retina. Now, we talked about if patients are not taking ACE inhibitors, where did the ARB data come from? And these come from CHARM study, and then the CHARM had another called CHARM alternate. This was Candacertin study, and Valhaft was a Valcertin studies. These are old studies. Now these drugs are all generic. And you can see that the effects, if the survival was better with the better complete placebo, and Valcertin is here, and the CV death or hospitalization was less in CHARM study than the placebo. When we say placebo, these people were on beta blockers at the time. Again, these were old studies. In fact, when I was a study coordinator in my hospital before I went into residency for CHARM trial, and they put us in this fancy hotel, which I never ever thought about it, in St. Petersburg, Florida, and that's how I realized that why these drugs are expensive. They spend so much money on me. The other new drug which is coming is it's neprilysin inhibitor, and what these neprilysin inhibitors are, these are natriuretic peptides, and we have ANP, BNP, and all those. And these neprilysin inhibitors increase the levels of these ANP, BNP, or natriuretic peptides, and help out. So this is again the renin angiotensin aldosterone system, and they are going to the bottom of it, and they also affect the metabolism of angiotensin at angiotensin receptors. Um, and the study is called Paradigm Heart Failure. You would be seeing these people walking around selling this drug named Entresto. This is about this. And when they had this trial, it was LCZ696, and it's a combination of sacubitril, which is neprilysin inhibitor, and valsartan, which is an ARB. So you can right away start these patients on these medications where we were doing ACE inhibitors. You can start them on this combination. Outcomes are good. Medication is expensive. There is increased incidence of angioedema. Otherwise, most of the side effects were the same as you can have hyperkalemia because of valsartan, etc. So be very careful when you are initiating. Initiating these drugs can cause hypotension. So start with low dose and slowly go up on those medications. I am not yet totally sold on it. But again, this is very, the data is good. The science behind is good. And if we have a selected population of patients who can afford these drugs and are going to take these drugs, then that's a good thing. Remember, we talked about it. If the patients stop these drugs, they feel worse, the hospitalization is increased, the risk of mortality increases. Anytime a patient is admitted with heart failure to the hospital, the risk of mortality increases. So be very careful that they can afford the drug, they have a good supply of drug, so they do not stop the drug when the samples are over. It's very, very important to understand that. One very good, so you are talking from here renin, then we have angiotensin, and then we have aldosterone. And in 1999, when I was doing my residency, this trial was published for spironolactone, and spironolactone is worth a month worth supply, maybe 25 cents. This is such a cheap drug. And if you look at this, this is a absolutely wonderful drug where it right away started working, and if you see there's 20-30% reduction in primary endpoints and secondary endpoints. So cheap drug, very good drug. And the commonest side effect is hyperkalemia. And one another side effect which you guys most of us have seen is gynecomastia, because now this drug is used very commonly. On a sidebar, this is for the clinicians here, and my personal experience. If the patient has obstructive sleep apnea, or if patient has resistant hypertension, and you are having difficulty, use this drug and see the magic. You know, the blood pressure comes down 20-30 points in those situations. So aldosterone antagonists are an absolutely wonderful, cheap drugs which can be used. And if you have gynecomastia with spironolactone, then there's eplerenone, which is, this FSS trial was in post-MI patients, but in my practice, if they are unable to tolerate spironolactone, I use eplerenone, 25 milligrams usually, but sometimes maybe 50 milligrams. Again, the data is very clear. The FSS trial was done in post-MI patients, but now it's a consensus that it can be used if the patients are intolerant to spironolactone. So we talked about when you are using, so remember we have added spironolactone on people who are on ACE inhibitors, ARBs, or this newer combination now, and they all cause hyperkalemia. So in my practice, whenever I start spironolactone with ACE inhibitors, ARBs, then I check their potassium quite often. 3 days, 7 days, 2 weeks, 1 month. I keep on checking them till I am confident that they are not going to develop hyperkalemia. And we see a lot of patients once a month or so where we see there is some hyperkalemia. And there may be sometimes they are taking their potassium supplements. So make sure that you stress this point that they do not take any potassium supplements, over-the-counter supplements, or the potassium pill they had from way back when. Other thing is if your creatinine is 2.5 and above, avoid these drugs. And do not use too many of potassium sparing diuretics. So spironolactone, don't use it. Trimetrin, like general pharmacological principles which we follow. There will be some patients where we would be using a lot of diuretics which will come to them, and they will develop hypokalemia. And in those patients, you will use potassium supplementation. And hyperaldosteronism patients, you will see that they are hypokalemic. And in those cases, when you are using your potassium, be very careful to check it. We have one patient which has not been in hospital recently, but on high doses of both medications along with potassium supplementation, and we were able to keep his potassium up, and all of a sudden he became hyperkalemic, and we had to stop potassium, and his potassium runs between 4 and 4.5. So if we have not checked that guy's potassium, either he would have had severe hyperkalemia related complications, and hyperkalemia can cause hyperkalemia is fatal. And that's the potassium chloride is the drug for what? Execution, you know that. So we have to be extremely careful about these things. Here, and it's on a sidebar, here comes your nursing staff, your associates in taking care of patient. We have some people here from our office, and our staff goes through all these labs very carefully and are on top of it, and that's why I think we have less of complications of these issues. So your support staff is extremely important. Now we talked about hydrolysis in nitrates, and this all-HF trial, which was the cornerstone. Again, it's a very old trial, 10, 12 years old trial. And if you look at this number, it's amazing. If it is projecting okay, otherwise it's 43% decrease in mortality. How many times you see these things? So remember, and the goal, the reason it is happening is because of afterload reduction. And what does hydralazine do? Decrease blood pressure. What does IMDUR do? Decrease blood pressure. What is the blood pressure patient coming with? 100, 110. So nursing staff, please remember why we are doing this, and try to assess the patient. Unless until the patient has symptomatic hypotension, we can still try these medications. So what people think about these, again, this is the last minute funny, so I don't know if it makes sense here or not, but you try to make it. But the problem is all these breakthroughs which I am talking about are not happen in one year, or they some brilliant scientists here. You know, the first time when they gave beta blocker, I think it was in Europe, when they gave beta blockers in patients with heart failure, the chief or whosoever the big boss was said that I will not give a beta blocker to my dog. Why do you want to give to the patient? And the guys stuck it. And with that comment, I heard that heart failure treatment was taken aback by 3 years, because it is very, very counterintuitive. But the guys were very persistent. They knew their biology, they knew their science, and they persisted. And now we are doing so well in heart failure treatment. So breakthroughs are, you take it with a pinch of salt, but not with like this guy. Okay, so the other thing is you have eaten a lot of salt now, because you have read through a lot of breakthroughs. So our patients have a lot of volume. And in treatment of heart failure, loop diuretics are still the key. Now we will talk about metolazone, but metolazone alone does not work. So loop diuretics still is the key treatment. And you will see that we someday will do 40 milligrams of Lasix, someday we'll do 20, someday we'll do 80. And what are we looking into is volume status of the patient and how it is helping out. And there are a lot of controversies because we do not have time. These are the principles you usually use. You use dosages in multiple, as least as possible, and multiple dosages. That will be more effective. But the curve is an S-shaped curve, so to be on the effective dose, you need to have certain amount of dosing. So if your 20 is not working for a Lasix, you can go 40, and same thing with the torsemide. Sometimes oral torsemide, when you're transitioning, and if they're failing oral Lasix, then you can use oral torsemide. All hospital patients usually are admitted because of IV diuretics, but sometimes in office also we do a dose of IV diuretic because we know the absorption is, bioavailability is 100% in by definition with that. When the patient says the Lasix is not working, it's mainly non-adherence or the kidney problem. So, and the third and most important is his heart is failing. So we need to look into it. So when your diuretics are not working, it's a bad situation. So look into all these things. Now, if you look into it, we can give a lot of diuretics, and you can give till the patient becomes deaf. 600 milligrams of Lasix, they will become deaf. But you can use a lot of diuretics if it is escalating doses of diuretic, but then the side effects are more, and also the effectiveness or efficacy becomes less. I'm sorry I had to go fast on these things. Digoxin, usually for symptom relief and rate control in atrial fibrillation. It's an old drug. We still use it because most of the trials, wherever you give digoxin, the patients, there's some increased mortality. And I think the reason for that is these patients are sicker, and we are kind of pushed to the wall, and we do not have too many options, and there's where we use digoxin. So, but anyway, if you can avoid digoxin, but there will many of our patients are there, and it's a symptom relief, and there are studies which shows decreased hospitalization because of digoxin. Now let's come to the device therapy. You have the questions arise about internal cardiac defibrillators and where to use them, and this is pretty much set in stone in these things because of very high cost of these things, and Medicare looks into it very closely. They're very expensive, and these are for LVEF 35% or less, and you have to have mild to moderate heart failure symptoms. And if you are going for a bi-V pacing, we'll talk about why use of a device that provides defibrillation can be thought about it at that time. So there may be some times when you are using bi-V pacing, and that time you can say, okay, there's a lax in this rule. And not everybody who has ejection fraction 35% or below should be getting devices, because that's where your art of medicine comes in place. Is you look at their functional status, you look at their prognosis, underlying heart failure, comorbid conditions, and we usually want 3 to 6 months of 3 to 6 months of optimal medical management. That doesn't mean you put a little bit of beta blocker and ACE inhibitor and they are optimized. You keep on escalating the doses, check their EF and all that. Nowadays, there is a new thing called LifeVest, which we are using. This is an external cardiac defibrillator. It's pretty expensive. The company says they do a wonderful job. I still don't know. Cardiology community, if I read the forums, is divided on this. I have not had a single patient who likes that LifeVest, but I think it gives us a lot of assurance that patient is covered when we have not put an internal cardiac defibrillator. Bi-V pacing is mainly for patients who have who are in sinus rhythm, had a wide QRS complex and severe LV dysfunction, and they have to have moderate to severe heart failure symptoms despite optimal medical therapy, and this has to be persistent. It's not that one time a patient comes in with heart failure and you put a Bi-V pacing. They have to be persistent symptoms. Sometimes in a patient who have chronic pacing, and lot of RV pacing is expected, then we do Bi-V pacing, and there are trials called AV trial and other trials which have shown that RV pacing may not be very helpful, and it may be at times detrimental, so we do a Bi-V pacing in that regard. Here's the all-cause mortality on CARE heart failure trial, where medical therapy was worse than CRT, so there is some mortality benefit also to CRT. And that's the reason you see that we have CRT means resynchronization therapy, so is used quite a bit. Our EP colleagues and I think Dr. Christensen here in the hospital are doing these procedures, so you can send the patients to them for evaluation if you think so. One important thing is most of our patients get symptoms or side effects from these medications, which need to be carefully evaluated. Many a times the patients will quit the medication first and let you know later, or you see them in the hospital when they are decompensated, because this is a real stuff which you have to consider. Now, surgical approaches to heart failure. Heart transplantation is still the gold standard if you have heart failure, and there are rules and regulations for that. But only 2,000 heart transplantations happen. We need 20,000, the big gap and all that. So we'll talk about some other things. So severe heart failure, debilitating refractory angina, or ventricular arrhythmias qualify you for that. And then you have to have a very good workup in a center. Usually it's the advanced heart failure clinics which run these things. We have one in Des Moines, which is staffed by brilliant people. And we do not have a heart transplantation program at Iowa Heart Center right now. So these are multidisciplinary medical and surgical teams, and they do all these work. So if you have patients who are you feel are not being able to help in your regular practice, then advanced heart failure, and we'll come to that. Mitral valve repair and replacement. Again, mitral regurgitation is very important, and if your LVEF is low, there are multiple studies which shows that severe LV dysfunction, if you have LV dilatation, you have missed the boat, and if you do mitral valve surgeries, they do worse. So it's not generally recommended. And there was one partial left ventricle resection came up, but it didn't fly, and we don't recommend it anymore. There are another trials coming, like parachute trials and other things, and Iowa Heart Center research department is enrolling patients in that. Again, they are all not yet online. Now, if you have an acute decompensated heart failure, which you get a call from ER to manage these patients, so you have to look for, is there atrial fibrillation is the commonest thing which I have seen here. They come with the AFib with RVR and they are in heart failure or some sort of an SVT. The other common thing is severe hypertension, which we see. Myocardial ischemia and infarction, people with ST elevation myocardial infarction, we see them, or severe three-vessel disease or severe ischemia or non-revascular valve disease can have this. Usually they have pulmonary congestion, and sometimes we can see non-cardiogenic pulmonary edema too. I talked about we see patients with anemia and heart failure here in the hospital all the time. We had one in which we admitted this morning. There is a thyroid disease we talked about, and significant drug interactions can cause this thing. So I would like to thank our pharmacy department. It's an absolutely wonderful department where we call them and they run these drug interactions. They check all these drug interactions, and thank you very much for your team. You have done a wonderful job in taking care of your patients here. We need to, there are certain other things which are coming up, but I would just, because this is what our hospital does, is a BNP, check a BNP whenever you are in question. And if your BNP is normal, very seldom you will have heart failure. And obviously we look for symptoms. And when do we hospitalize these patients? When they have symptoms of decompensated heart failure, hypotension, worsening renal failure, altered mentation, and these are the people who usually go to the unit. And if you have dyspnea at rest, do not go with the oxygen saturations. Your oxygen saturations may be normal or above 90, but if you are having dyspnea at rest, or they're sitting at the edge of the bed, short of breath, and oxygen saturation is okay, they are still in heart failure. And again, arrhythmias. Acute coronary syndromes, we are very particular about it, and now we have Dr. Shapiro who is doing interventions here, Dr. Bhatt is present most of the time, and we will have one more interventionalist coming online pretty soon. So we would like to treat the ischemic heart disease very aggressively, and these really give acute coronary syndrome. Revascularization saves lives. So we have to be very careful, and please call us whenever you feel that this is going on. And we talked about all these things: major electrolyte imbalances, weight gain, repeated ICD firings, and we need to correct the underlying condition. If you do not correct, if there is a pneumonia, if there is hyperthyroidism, if there is ventricular arrhythmias, if you do not correct that, then we are not going to get anywhere. I need to go up 5 minutes, so if you can give me 5 more minutes. So supportive care, oxygen, IV diuretics, loop diuretics, continued infusion of loop diuretics, and other things are important. And then venodilators can be used, like nitroglycerin or nitroprusside in acute. Again, these things don't make sense. Why would you use nitroprusside in a guy who's but they work in acute settings, and we sometimes do that. IV inotropes usually don't work for long run. They are for short run. They improve the end organ function. And if the blood pressure is less than 90 and they are symptomatic, or they are not unresponsive, and they do not they are intolerant to intravenous venodilators. We usually do not want to do IV inotropes for long term, at least, unless until you have a right heart cath done and have checked cardiac index and filling pressures and all those things. So, and you will they have more arrhythmia, so you have to stop them. And this is what the trial is. If you see the placebo and the milrinone group, they are all the same. In fact, the mortality is initial in-hospital mortality is higher with milrinone group. So when we are starting these medications, they need to understand that there's an increased mortality, and this is mainly because of arrhythmias. Hemodynamic monitoring, like continuous monitoring, like doing a right heart catheterization, which we used to do quite a bit when I was in fellowship, but now this escape trial, you see there are 2 lines, but they are superimposing on each other, so it doesn't make much sense. So it turns out that the clinician still rules, your clinical skills still are important. Discharge planning is very important. Please read through it. You guys are all fast readers. You are doing it every single day. But it's very important, because if your discharge planning is not good, you will have increased hospitalization. And I don't know if Brian Dieter is here. I saw him in the hallway, and he would be not very happy. Maybe Neil will also not be very happy if we have too much of 30-day rehospitalization rates because of Medicare issues and payment issues and all those things. So discharge planning, again, our social workers, nurses, heart failure planners are very important. And in any heart failure program, this is the one important factor which we need to look into it. So medical dietary compliance, alcohol moderation, smoking cessation, all those good things we talked about. You need to address all these issues, and it should be in your whole in handout. And the other thing which the nurses here, and I see some 4th floor nurses here, is if you have a plan to discharge the patient that day, please prompt us if the patient is still on IV diuretic. So the plan is to discharge the patient. Do you want to because you may have seen, okay, patient is on IV diuretic, I want to have a PO dose and then see what the effect is and then send. This is where the data comes from. So I see Anita there and Jackie there. So that's where you need to and propagate into your colleagues also that why we want to do that. And nobody should be discharged within 24 hours of an inotrope support, because they will not do good. Advanced heart failure is when we have exhausted everything, and these are those things. And what we can do is, these are people who have repeated hospitalization, BO and creatinine increasing, they are having weight loss, like that is cardiac cachexia, and we see their blood pressure is coming down, and they cannot even walk a block because of their fatigued and dyspneic. And that's where these advanced heart failure clinics come. They may have repeated shocks and all those things. So if you see the clinical course of most of our patients, they do well. They they come back, their quality of life decreases, we treat them, and then they improve, then they keep slowly going down, then they will have a few dips, and then they will start having these dips. And the same thing with the intensity of care slowly increases. And here they have decompensations, here they have plumb failure. And this is where they should transition to these advanced heart failure programs. These are people who need a lot of work and a lot of team effort and all those things. And sometimes in our busy practices, we do not have time to take care of those, and we can transfer them to advanced heart failure clinics. I'll skip this. This is a 1-hour lecture, so I'll skip this. So mechanical circulatory support is nowadays you will see, and we will have to start taking care of the patients. And they are showing up in the ER, they are showing up in rehab clinics, and sometimes on the floor, is people with heart pumps. And the HeartMate is the biggest thing right now running. And when do you get is the mechanical circulatory support? So there one is non-durable, where there's a thing called Impella, and there are some other pumps and ECMO and all those. Where we are bridge to recovery, where an acute thing happened and we think the patient will recover in a few days, then we can do it. Or they are bridge to transplantation. But nowadays, most of us, what we call a durable mechanical circulatory support, are these heart pumps, and they are reasonable to prolong survival. And there will be, when the company guys come, they show us all those good things, but they come with a lot of problems. This is a complete lecture for that, and the people who do it can come and do a lecture if you guys are interested. These are Intermex classification to go who needs one. But remember, if you are if you are too good, and if you are too good, and if you put you through these devices, they are very aggressive devices, you will not do good. And if you are too sick, then you are too sick and you die. So optimal optimization of time to have these therapies is important, and that's where the advanced heart failure clinic comes in place. We have at Iowa Heart Center in Des Moines, in Laurel office, a nice advanced heart failure clinic where heart failure specialty doctors are there. We have a heart failure service. In Ames, we would be 3 people who would be certified in heart failure treatment. So this is another advertisement for you guys. So destination therapy trials, they do better. It's 106. Continuous flow LVADs are better than pulsatile flow. And this is a new thing when now they are trying to see people who are ambulatory heart failure patients and put them on these devices called HeartMate and other things. So this is HeartMate. These are LVADs, left ventricular assist devices, and they are very small nowadays. They come with a battery pack, and we have few patients here in our practice in Ames. They come through our Ames ER. There are CMS criteria for that. Read at your leisure tonight. And one important thing, if I may take a few more minutes, I beg your pardon, is palliative care. I don't see Joni here. Is Joni here? So palliative care consult is extremely important in patients who have advanced heart failure. And if they have frequent admissions, serious episodes of decompensation, we cannot do a heart transplant or LVADs on them. They have poor quality of life, low albumin, cardiac cachexia, and they are close to end of their life. And I think this is where we are lacking. We should be spending a lot of time, because this is the prescribed treatment. It's not giving up on the patient. It is helping the patient. And we have to be very passionate about it. And this is a very tough time for patients and the families. And compassionate time spent, explain them the situation, let them think about it, let them go through these processes. And I would congratulate Joni. She's not here. She does a wonderful job. So if you have patients, and the nursing staff can let us know and prompt us that you want Joni to come and talk to them, talk to the family, and it's a time-consuming process. So nothing is going to happen in 1 day or 1 hour. So we should start these conversations as early as possible when we think that this is important. Again, we talked about this end-of-life care. and inactivation of ICD should be discussed because we do not want the patient to the hospice with an ICD on, and that's a bad thing, and I think it has happened sometime somewhere. And remember, hospice services can be delivered at home, hospital settings, special hospice units, and other places. So they have multiple options. And inotropes like dobutamine are approved for palliative care. So we can give them a continuous dobutamine pump for palliative care. It's not going to increase their lifespan, no outcome changes except for palliation. And there are some companies which can do that. And we talked about rehospitalization. Thank you. I went over 9 minutes. I think they should give me more time. Thank you. Any questions? The question is there any difference between selective and non-selective beta blockers? The trial, COMET trial, was done with carvedilol, which is non-selective, and metoprolol, tartrate. So there is no head-to-head trial with selective and non-selective beta blockers. So in our practice, if you have a lot of arrhythmias or some COPD, then we use toprolaxel more. I like Coreg. So if I can use Coreg, carvedilol, I use carvedilol all the time. No head-to-head trial yet. So only three beta blockers approved are carvedilol, metoprolol, succinate, and bisoprolol. So we should be using these 3 beta blockers only in our heart failure patients.
What role might transfusion with packed cells, I presume, in someone with an anemia from some other cause and heart failure?
So anemia and heart failure, we do use transfusion. And its plain oxygen carrying improves. The problems with transfusion can be volume overload, so usually we do it with IV diuretics in between interpers. Yes, the symptoms improve, the oxygen carrying capacity improves. I do not remember any specific trial being done and reported about the outcomes, but yes, from our clinical practice, we like hemoglobin near 10. Hospitals don't like it, but we like it near 10. Yeah. Because of the transfusion issues, and now every unit is documented somewhere. So some hospitals have 8 cutoff, but if the patient is symptomatic, I would like it to be 10. Any other? I will look it up, but I do not think there is a placebo-controlled trial or anything. It's very hard to do one. Thank you very much.